Okay, infant CPR, much like child CPR, there are just a few changes, and we're going to focus on mostly those changes, but also use this as an opportunity to review CPR once again. So, an infant is up to 1 year old. So, up to 1 year old, we treat them as an infant, and we're going to do some things a little bit differently than even we did with the child. So, it starts the same way with scene safety, making sure you have your gloves, making sure you have either a pocket mask or a BVM. Now, if you have an adult pocket mask, it can be a little bit challenging to get a good seal on the patient's face because it's not made for an infant. So one trick that you can use is if you have a pocket mask, you can actually turn it upside down so that the skinny part, which typically goes on the nose, will actually go across the infant's chin. And then the big part it'll go over their eyes, but that's okay because it'll include their mouth and their nose, and you'll have a good seal around that chin. If you try to put the big round part along the infant's chin, it's too big and air will usually sneak out from the mask. So if you have an adult-sized pocket mask or an adult-sized mask attached to an infant BVM, you might have to turn it upside down. Now, as far as the BVM, if you're using the bag, you want to make sure you have the appropriately sized bag. You'll see in a couple videos here, first of all, how much smaller the infant bag is than the adult bag, but also it's just a tiny, tiny, tiny amount of air that you're going to need to give that infant a breath. And it's really difficult to have enough self-control to squeeze that big giant bag just the tiniest little bit. You just can't really control the airflow out of it like you can with an infant BVM. Okay. Now, if you don't have a pocket mask or a BVM at all, and either you know that infant's medical history, or there's a caregiver with the infant, which is pretty common that an infant would have somebody with them, you could instruct them on how to give straight mouth to mouth. To give those breaths, instead of pinching off the nose, infants mostly breathe through their nose. Their nose is pretty large of an airway compared to their mouth. So you'll actually seal the lips around the mouth and the nose of the infant, still tilting the head back to open the airway and then giving a breath, again, just until you see chest rise. And we'll talk more about that when we get to the breaths for the infant. Again, scene safety, make sure the scene is safe. One thing with an infant, you may be able to carry them with you to a safe area if you already have them, and you can get to a safer area. Or call for additional resources to secure the scene before you enter. Okay, so let's look at these different size BVMs here.
So we have 3 different size BVMs here. This is the one we use for an adult. This is the one we use for a child. This is actually the bigger of the 2 pediatric sizes that you can get. There's another one that's for a child that's even smaller. And this is what we use for an infant. So keep these sizes in mind when you are giving someone breaths with a pocket mask. You're not going to squeeze this all the way down when you use the BVM. So you're not going to use this total amount of air, but this is a good guideline because this is the most air you'll ever need for an adult, the most you'll ever need for a child, and the most you'll ever need for an infant. So when you're giving breaths by mouth, you're really going to have to give a lot less air for a child and for an infant. So just keep this visual image in mind as if you're doing that.
So if you're giving the breath to an infant, you might find the best way is just to fill your cheeks with air. Basically, the amount of air that infant BVM holds is about the amount of air you can have in your mouth. So you may do the breaths like this. Either if you're using a pocket mask or if you're doing mouth to mouth, just so you don't accidentally give too much air.
So we have 3.
Okay, just like the adult, we're going to start with AVPU, see if they're responding to us as we walk up to them. If not, we're going to try to tap them and try to wake them up. If that doesn't work, we'll go for a painful stimulus. You can still pinch their shoulder, or you can flick their foot or something. Now, when we get to checking the pulse, this is different. Babies have a really flexible, really soft trachea. The trachea is made of cartilage. If you go poking around on their neck trying to find their carotid pulse and you collapse their trachea, instead of it being round, it will flatten and it will not bounce back to shape. It's made of cartilage and it will stay collapsed. So now we don't have an airway because the airway's collapsed. So never poke around on an infant's neck and never try to get the carotid pulse for an infant. Instead, we will try to get a brachial pulse. The brachial pulse is along the humerus, so along the upper arm bone. You'll push their little baby bicep up out of the way, and you can feel along their entire humerus with 2 or 3 of your fingers, and you'll feel that whole length of the bone, and you'll find that brachial pulse somewhere along that upper arm. The other option is to try to get a femoral pulse. These are both considered central pulses instead of a peripheral pulse, whereas, your radial pulse or a pedal pulse, those are peripheral, but central pulses are carotid, brachial, and femoral. Now, the brachial pulse is a lot more difficult to find in an adult. If you try to find your own, your humerus is much longer. So there's a lot of different places where that blood vessel can be as you're trying to find that brachial artery. But in an infant, you can feel the whole arm at the same time, and you'll probably find it much easier. But that if you wanted to do that femoral pulse, that would be in the crease of their leg, basically exactly where their diaper lies, right in the crease of the leg. So you can try to find that as well. Just like before, if you're not able to find that pulse and you're not able to wake them up by pinching and they're not breathing, you can go into CPR. If they wake up when you start CPR, okay, they didn't need it. Infants can have agonal gasping as well. With infants, it's going to be a little bit harder to identify because infants are belly breathers anyways. When you look to see if they're breathing on their own, you're probably not going to see chest rise. You're probably going to see their abdomen rise and fall because they use their abdominal muscles to breathe. Sometimes in children as well, but especially infants. So if you see that belly rising and falling, just kind of take note. Is there air coming in and out of the mouth? If there is, that's true breathing. If there's not, that's probably that agonal gasping we've been talking about. That's just kind of a muscle spasm. Now, just to kind of clarify, when a baby's breathing on their own, you see their belly moving because that's where they're moving the muscles to pull the air into their lungs. However, when we ventilate an infant with a BVM or a pocket mask or mouth to mouth, we're going to see the air go where? It's not going to go into the belly. It's going to go into the chest. So we'll see the chest rise and fall, not the abdomen. So when you're ventilating, the chest rises and falls. When you're checking an infant to see if they're breathing on their own, you look at the abdomen to see the abdomen rise and fall. So just a slight difference than what we look at in adults. Just like the child, if they have a pulse less than 60, we start CPR anyway. 60 is a nice number because it's easy to remember and it's easy to check. There are 60 seconds in a minute. That makes it easier to remember. And then when you go to check the pulse, you don't have to count it for a full minute or even 30 seconds to see how fast it is. You can compare that pulse to the second hand on your watch. If the pulse is slower than your second hand, it's less than 60 beats per minute, and you should start CPR right away. You don't have to wait that full minute. Just compare it to your second hand, and if it's slower, it's less than 60. Okay, chest compressions for the infant, they still need to be on a firm surface. You're still going to do your chest compressions in the middle of the chest, but it's usually going to be slightly below the nipple line. So you're just barely below the nipple line. Adequate depth is about 1.5 inches instead of about 2 inches. We can still use, like we said before, 1/3 the depth of the chest. And again, that's the one that I like better. 1/3 the depth, 1/3 of the way down, because it's just easier to check, easier to see. That most of us don't know what 1.5 inches really looks like. That's a pretty hard to approximate, unless you maybe work in construction or something. Okay, 2 fingers to do the compressions. You can use your pointer finger and your middle finger to do the compressions, or you can use 2 thumbs, or as of those latest 2020 American Heart Association guidelines, you can use the palm of your hand if for some reason you're not able to use the 2 fingers or the 2 thumbs. Maybe if you have arthritis, some sort of injury to your hand, something like that, you can use your palm, or injury to your fingers, I should say. You can use your palm. We are looking for adequate chest recoil, just like before. I see people make this mistake a lot with infants because you're using your fingers rather than your whole body weight. It's easy to keep those thumbs compressed. So make sure when you do those thumbs or fingers that you're letting that chest come all the way back up to its full height between each compression. And as I've said, it's always, always, always the same speed. It's always 100 to 120 per compressions. It doesn't matter how many patients you have, what age they are, how many rescuers they have, what size they are. You always go to the beat of staying alive. It's always that same speed, between 100 and 120 compressions per minute. So let's look at those compressions on a baby and those different options and what they look like.
For our infant chest compressions, we have a couple different ways we can do the compressions. They kind of suggest different compressions based on how many people are on scene, just because of how it's going to be quicker to switch between compressions and breaths. So if you're on scene alone and you're doing one rescuer infant CPR, they suggest the 2-finger technique. So you're going to have your 2 fingers just below the nipple line. So I put my pointer finger between the nipples, and that causes my middle finger to fall just below that. Using those two fingers to do the compressions, we can do them this way. That way when I'm ready to give breaths, it's going to be really quick for me to switch from here to here. Okay. Now, if I have a second rescuer helping me, it would make more sense that I would be at the feet of the patient and the other rescuer would be at the head giving the airway. So for one rescuer compressions for an infant, we prefer to use two thumbs encircling. So those two thumbs again are going to go just below the nipple line. Okay, we do our compressions that way. And then when it's time for breaths, I don't have to move. I can just stay here. Now, if you're trying to do the two finger compressions and you're by yourself and you're not getting good compression, because this does take a lot of finger strength, it's best to get those compressions. So if you need to, you could reach from the side and do your compressions this way. If you're by yourself, then when it's time to give those breaths, you can move pretty quickly from here to give those breaths. Okay? And then as of the latest and greatest 2020 AHA guidelines, if you're not able to get those compressions with two fingers or two thumbs, you can switch to one-handed compressions. Now, you're not going to be using your whole body weight like you would for an adult or a child. You're just using your hand. Basically, the strength of your wrist would be enough. That would only be used if you're not able to use two fingers or two thumbs. So if you had some sort of injury or weakness to your hands, you could use that full hand. For our infant.
Okay, for the breaths for the infant, still going to make sure we open the airway, typically with that head tilt chin lift. Now we have to be a little bit more cautious with opening the airway for an infant because their occiput, remember the occiput is the back of the head, the rounded part of the head towards the top. The occiput on an infant is very large. So you have to be careful not to hyperextend their neck as you tilt their head back. We kind of use the occiput like a fulcrum or like a lever, if you will, to open the airway. We kind of roll on that occiput. So with that larger occiput, it can be really easy to accidentally roll their head back too far. And to demonstrate what this does, if you'll just take a second and look straight up at the ceiling, look up at the ceiling above you, look as high up as you can. If that's easy, you can even look kind of behind you and you'll feel your throat close as you do that. When you look straight up, your throat kind of closes off. So the same thing can happen with an infant where we're giving those breaths if you hyperextend the neck. So you're kind of looking for that sweet spot. One thing that'll help you with that is, when we're doing CPR, we don't always have time for these kind of things, but if you're ventilating and you have extra hands, somebody can help you. If you can put something under the infant's torso to raise them up a little bit so that their head kind of dips down, that will help keep from overextending their head. Or their neck. That's just one way. On the infant, if they had a possible spinal injury, we would do that jaw thrust instead of the head tilt chin lift, just like we did with the adult and the child. We want to get a good seal with the mask. You're going to use usually just a thumb and a finger around the mask to hold it to the face, and then your other three fingers under the chin to tilt that head back to open the airway. Now this one, as I mentioned with the child, it's even more difficult with the infant, giving the breath over the period of 1 second. So it's a nice and gentle squeeze, and we'll see this in the video because when you see it, it makes more sense. And just like the adults and the children, we want to limit time off the chest. Anytime you could possibly doing chest compressions, you want to be doing those chest compressions, getting that blood flow circulating, getting that oxygen circulating, all that good stuff. So let's take a look at the breaths here.
For our infant chest compressions, we have a couple different ways we can do the compressions.
Oh, that's the wrong video. Let's stop right there. So let's have a look at the infant getting these breaths here.
Now, giving breaths to an infant is, I don't want to say it's tricky, but you have to be really careful because they have smaller lungs and we don't want to give too much breath, too much air. The same principles apply as applied to a child and an adult, is that we only want to give breath until we see chest rise. But we just have to be more careful because it's such a small amount of air. If we use an infant BVM, that's ideal. You would never want to use an adult or a child BVM hooked to an infant mask for an infant. There's just too much risk of accidentally giving too much air in the lungs. But if you didn't have this and you were using a pocket mask, it would be a good idea to just fill your cheeks with air. Basically what you can fit in your mouth is probably going to be enough to get chest rise. Just like before, we want to get a good seal on the mask. Don't be afraid to put your hand over the infant's face. We want to get a good firm seal. So with this hand, I'm being pretty firm. I'm putting a lot of pressure on the face and the mask. I'm also using my hand to tilt the head back to open the airway. Now, in addition to opening the airway, I need to squeeze the bag. Notice that I'm really just using 2 fingers on this bag very gently. Again, just until I see chest rise. It's common for people to want to grab this bag with the whole hand and do one of these, and that's way too fast and way too forceful. So instead, I suggest just a thumb and a finger and giving it a light pinch. Just like the adult, we want to give this breath over the period of 1 second. So 1 Mississippi, 1 Mississippi, just like that.
Okay, putting this all together, just like the child, for the same reasoning. If you're by yourself, you're going to do 30 compressions to 2 breaths. If we try to do less compressions to breaths, we waste too much time trying to switch between compressions and breaths. Just like the child, if we have 2 or more rescuers, we are going to switch and do 15 compressions to 2 breaths. Just because it's going to be much quicker to switch, and these infants have a higher oxygen demand. So the 15 to 2 is what's best for them if we can limit our interruptions to chest compressions to quickly get those 2 breaths in. Just like the child and the adult, we should swap the compressor out every 2 minutes. It's not as exhausting, maybe you're not getting short of breath doing compressions on an infant, but your thumbs or your fingers get very, very tired pretty quickly. So that 2-minute mark, your compressions are not going to be as effective. Just like the adult and the child, you should apply the AED to the infant as soon as it's available. So we're going to watch a video now of putting this all together and doing the full CPR scenario on an infant.
Okay, infant CPR. So we just found this infant who's down, and we need to determine whether they need CPR and then perform 1 rescuer CPR. So I arrive on scene, I have my personal protective equipment on, the scene looks safe, I'm going to approach the baby, tap them, they do not respond. So I'll go for a painful stimulus by squeezing that trap muscle to see if they respond. If they do not respond at this time, I will either call 911 if I'm not on duty, or if I am 911, I'll call for ALS. I'm also going to call for an AED. So I need ALS and an AED. Now I'm ready to check the patient's pulse and breathing. Remember, for the infant, we cannot check the carotid pulse, so I'm going to check that brachial pulse. Now I would typically check it on the same side, but just so you can see for the camera, I'm going to check that brachial pulse in that upper arm. There we go, you can see it. So I'm going to check that brachial pulse, as well as checking for breathing. I'm listening for air movement, watching for chest rise and fall, and feeling for any air coming out of the mouth and nose. No pulse, no breathing, or any pulse below 60, I'll start CPR. 10, 15, 20, 25, 26, 27, 28, 29, 30. 2 breaths. Back to chest compressions.
Those breaths were probably a little bit too fast. I got a little excited there.
10.
See how I do on the next
15,
round.
20, 25, 26, 27, 28, 29, 30.
Those were a little slower, but they could still be a little bit slower over that period of 1 second.
10.
It's challenging because you're going fast on the compressions and then you need to go slower on those breaths.
20, 25, 26, 27, 28, 29, 30. I can feel my fingers are becoming fatigued, so I'm going to switch to 2 thumbs encircling.
First breath was a little better.
10, 15, 20, 25, 26, 27, 28, 29, 30. Giving my 2 breaths. As you can see, that was a little bit slower to transition. And I will continue that until my AED arrives. When the AED arrives, I'll turn it on first and follow the prompts. To apply the pads, they would overlap if I put them in the front of the chest. So I'm going to place one in the middle in the front of the chest, roll the infant over, and place one on the center of the back.
Apply pads.
Analyzing wall, staying clear.
Do not touch the patient. Shock advised. Charging. Stay clear of patient. Deliver shock
All
now.
clear, shocking.
Press the shock delivered.
Continuing CPR.
Begin CPR.
Okay. And then for the infant, just like the child, if they have that advanced airway in, again, we'd see a tube coming out of their mouth because they've been intubated or had an iGel or a king placed by a paramedic or somebody with ALS training. Our compressions become continuous. So we no longer have to stop our chest compressions to give breaths. We just keep going. We might still count to 200, so we can swap out every 2 minutes. And then the breaths, just like for the child, as of 2020 for the new AHA guidelines, we're going to give that breath every 2 to 3 seconds. So the person doing chest compressions will just keep going nonstop, and the person giving breaths will give that breath every 3 seconds.